Toothwear is an important topic in restorative and preventive dentistry, and one that every clinician will encounter frequently in practice. By definition, toothwear is the progressive and irreversible loss of dental hard tissues by processes other than dental caries or trauma. It is considered non-carious tooth surface loss, and results from a combination of mechanical and chemical processes. There are 4 types of toothwear, which often overlap in the same patient. Attrition refers to tooth surface loss from direct tooth-to-tooth contact. This is a physiological process to some extent, but it can be pathological in patients with bruxism or parafunctional habits, where wear facets and flattened cusps are seen. Abrasion is mechanical wear caused by interaction with foreign bodies, most commonly aggressive toothbrushing or the use of abrasive pastes, but it can also result from habits such as nail biting or holding objects in the mouth. Erosion is the chemical dissolution of enamel or dentine by acids not derived from bacteria. This can be intrinsic, from gastric acid exposure due to reflux or eating disorders, or extrinsic, such as frequent intake of dietary acids in soft drinks, citrus fruits, or sports supplements. Finally, abfraction describes microstructural loss at the cervical margin, thought to be caused by occlusal loading and flexural stresses that create wedge-shaped defects, although it is often seen in combination with abrasion and erosion. To systematically assess patients, clinicians can use the Basic Erosive Wear Examination, or BEWE. This is a simple screening tool that records the most severely affected surface in each sextant. The scoring is as follows. A score of 0 means no surface loss. A score of 1 indicates initial loss of surface texture still in enamel. A score of 2 means a distinct defect into dentine is present, with less than 50% of the surface area affected. And a score of 3 indicates hard tissue loss affecting 50% or more of the surface area. The highest score in each sextant is recorded, then the 6 sextant scores are added to give a cumulative BEWE score. This cumulative score helps determine a patient's overall risk level and guides management and recall planning. A total score of 0 to 2 represents no erosive toothwear risk. In these patients, no specific intervention beyond routine preventive advice is required, and they can be seen at standard recall intervals with BEWE taken again in 3 years. Scores of 3 to 8 indicate low risk. These patients should receive oral hygiene and particularly dietary advice, and should be monitored routinely with BEWE being taken at 2-year intervals. Scores between 9 and 13 place the patient in the medium risk category. Here, previous preventive strategies must be reinforced. Fluoride measures such as high fluoride toothpaste should be considered and avoidance of placement of new restorations. Monitoring with use of BEWE should be repeated at 6-12-month intervals. Finally, a cumulative score of 14 or more places the patient at high risk. These cases are often complex, with widespread tissue loss, and may require restorative rehabilitation in addition to close ongoing monitoring in combination with previous prevention strategies and monitoring every 6 to 12 months. Monitoring toothwear is a critical part of care, especially for medium and high-risk patients. Relying on memory or a vague description in the notes is not sufficient. Instead, we should use objective methods to record the condition and track changes over time. Clinical photographs provide a visual baseline and can be repeated at each recall to detect subtle progression. Study models, whether traditional plaster casts or digital models, are another reliable method of monitoring. Increasingly, intraoral scans are used, which allow highly accurate 3-dimensional comparisons across time points, making it easier to quantify small but clinically significant changes in tooth structure. These methods not only help the dentist track progression, but also serve as excellent educational tools when communicating with patients about their condition. Management of toothwear is tailored to the risk level and underlying etiology. The cornerstone is always prevention. Patients should receive clear advice on modifying risk factors, such as reducing the frequency of acidic food and drink consumption, avoiding brushing immediately after an acid attack, and managing intrinsic sources of acid such as reflux with appropriate medical referral if necessary. Habit counseling for bruxism, including the use of night guards or splints where indicated, is also important. Regular topical fluoride application, high fluoride toothpaste and remineralizing agents can be prescribed to strengthen remaining tooth tissue and reduce sensitivity. For patients with more advanced wear, preventive advice alone may not be enough. In these cases, restorative intervention can protect vulnerable areas, restore lost function, and improve aesthetics. Composite resin is commonly used in a minimally invasive approach, while more severe cases may require indirect restorations such as onlays or crowns. However, it is crucial to remember that restorative management should be carefully planned and ideally delayed until disease progression has been stabilized. To summarize, tooth wear is a multifactorial process of non-carious tissue loss. It can be classified as attrition, abrasion, erosion, or abfraction, often in combination. Screening can be carried out efficiently using the BEWE scoring system, which provides a cumulative risk score and informs recall and management strategies. Monitoring should be undertaken through objective methods such as photographs, models, or scans, and management should be risk-based, beginning with preventive strategies and escalating to restorative care only when necessary. Early recognition and structured management are key to protecting patients' dentitions and maintaining long-term oral health.